Okay, there's too many people here for me to give a personal shout out to everyone, but I see all of you. Thank you for being here. Welcome to Chillin with Chitnis. My name is Shelly Korean, Executive Director of SkyPass Foundation, and I am joined by my co-host for tonight, Dr. Shilpa Chitnis, Movement Disorder Specialist at UT Southwestern. Shilpa also sits on the board of directors here at SkyPass Foundation, and we are here to have a very important conversation on cognitive, mental, and behavioral health issues in PD, a topic that I know you guys have firsthand experience with and you have a lot of questions regarding. So we are here to answer all of those questions. But this is interactive, which is why we've designed it this way as a Zoom meeting. It's meant to be interactive where we can all see each other. So if you've got questions, put those in the chat box, or you can also ask your questions verbally. Simply unmute yourself and we will get to as many of those as we can. This is being recorded. For those of you guys that are joining us live, just know that the recording will be put on YouTube. So if you don't want to be in the video, go ahead and turn your cameras off. We typically edit it to where participants aren't seen anyway, but just in case, go ahead and turn that camera off if you don't want to be seen. One last thing before we jump into this discussion. April is Parkinson's Awareness Month, and we want to highlight our mission and be intentional about communicating why we do what we do. So just a little bit about SkyPass that I want to share before we move on to our discussion. SkyPass Foundation is a nonprofit based in Dallas, Texas, and we are the nonprofit arm of a corporate group of companies. So SkyPass Group is the parent company, and under that, you've got all of these different for-profit entities, and SkyPass Foundation is the nonprofit arm of SkyPass Group, the SkyPass Group of companies. The owner and founder of SkyPass Group is a man by the name of Victor Abraham. Victor's dad, known as Captain P.S. Abraham, had Parkinson's, and his battle with Parkinson's ended in 2014. He was actually treated by our very own Dr. Shilpa Chitnis. And when he passed away, Victor wanted to do something to give back to the Parkinson's community in honor and memory of his dad. So it's cool to see how things have just come full circle, because now we've got this foundation that's serving the Parkinson's community in honor and memory of Captain P.S. Abraham. And we also, of course, have Dr. Shilpa Chitnis, who's on our board and works with us on our Parkinson's related initiatives. And so we just want to be intentional about mentioning that. And we just want to highlight the fact that this is all being done in honor and memory of the life and legacy of Captain P.S. Abraham. I'm sure he's looking down on us from up above with a big smile on his face, and especially happy to see how Shilpa is so involved in helping us serve the Parkinson's community. Thank you all for being here. Thank you for supporting our organization. We want to make this a conversation that is not stigmatized. We know that this topic of mental health is something that has a lot of stigma attached to it. We want to encourage open, unashamed conversations. So please ask your questions. We want to make sure that we answer all of your questions and get you connected to helpful resources. So with that, Shilpa, I'm going to hand it over to you.
Is there any medication that is immediately effective in stopping hallucinations when one was caused by a panic attack? Yes and no. I mean, so if we were to reduce let's say that you were taking 2.5 tablets of Levodopa 5 times a day, and you started hallucinating, and you called me in the middle of the night, I'm on call, and there is nothing else I can do, the pharmacies are closed, then I would say, why don't you just drop it to 2 tablets, 4 times a day, and basically, just by reducing the dopamine, the hallucinations can get better. But quetiapine or Seroquel and Clozaril or clozapine are probably the medications that I might use. Now, in people that hallucinate, that do not have Parkinson's disease, the psychiatrist will use psychotropic medications such as Haldol or Risperidol. Remember that we cannot use these medicines in Parkinson's patients because Haldol and Risperidol will block the D2 dopamine receptors and make Parkinson's motor symptoms worse. Sometimes it can even make people go into, a Parkinson's hyperpyrexia syndrome, which can be dangerous. So, medicines that block the D2 receptors are dangerous. So I think that short answer to your question is, lower the dose of the dopaminergic medication, quetiapine. Clozaril or clozapine is something that only the psychiatrists use. because it needs to be monitored. In 1% of the patients, it can cause fatal, I'll say the term fatal agranulocytosis. What agranulocytosis is reduced white cell count. So it can reduce the white cell count tremendously, and neutrophils, which basically fight infection, get significantly reduced. So if you are going to be on Clozaril, you need to do your blood counts, every week for a period of time, and then it's every 2 weeks, and then a little bit later. But the psychiatrist basically, give these.
I noticed that my dad believes that things are not true. For example, he is convinced that my sister is trying to sell his house, which is not true. We tell him this isn't true, and he gets very agitated and angry. How do we handle / diffuse the situation?
And he has Parkinson's, right?
Correct.
That is Parkinson's. Yeah. So this is psychosis. What he has is basically psychosis. This is, paranoia. Remember I said, I'll repeat this again, psychosis is not just visual hallucinations. It is basically presence, it is shadows, it is delusions and illusions. So what this is a psychosis, you need to talk to the movement disorder a doctor and appropriately get the psychosis treated. Of course, it is also important to rule out certain things such as infections. Patients with, elderly patients with Parkinson's disease can get urinary tract infections. Of course, people are at risk of developing aspiration pneumonia because of, difficulty with swallowing and the food going into the lungs. So when somebody starts having these symptoms, the first thing that I will do is I'll basically say, let's check CBC. So that's blood count to see if there's infection. Let's check, chemistries for liver and kidney function. Let's check a UA. That's a, urine analysis and urine culture. And then basically, if there's a UTI, you treat the UTI, you don't have to do anything more. But if it's none of that, and then it's, it's purely psychosis related to both Parkinson's as well as Parkinson's medications, then you really have to, either, the important thing to remember with psychosis and Parkinson's disease is I actually take people off a lot of medications before I put them on something else. So if they're on Contan, I take off Contan. If they're on amantadine, I take off amantadine. If they're on an agonist, I take the agonist away. And just taking away some of the dopaminergic tone, I may have to adjust the dose of levodopa, but I basically, try to keep older people and people with advanced Parkinson's disease. I basically treat only with levodopa, carbidopa, sometimes, with azolate, but none of the others. And even, none of the adjunct ones. And then, of course, if none of that works, then you have, and then one medicine I did not mention was Nuplazid or Pimavanserin, which has been approved for psychosis and Parkinson's disease. But as Dr. Devi was telling one of our NPs when she talked to him about how do I treat this patient with psychosis, and he gave, the same options that I gave now. And she said, well, why not Nuplazid? Because Nuplazid takes, a certain amount of time to work. It could take up to 6 weeks to build up before you can see the, the benefit of reducing psychosis. So, as somebody asked, if you want to reduce psychosis, instantaneously, then check for infections, check for metabolic things, take away any drugs that can help, reduce levodopa levels if they can tolerate without worsening motor symptoms. And then if not, quetiapine, Clozaril, Nuplazid, give these. DBS and weight gain, common and why? Okay, so patients, with Parkinson's disease undergo DBS for multiple reasons. Two of the important reasons are wearing off, which is motor fluctuations. Medicine doesn't last from one dose to the next. And the other reason is dyskinesias or involuntary movements. A lot of people, when they have dyskinesias and are moving a lot, basically end up burning a lot of calories and end up losing weight. What deep brain stimulation does, it really, reduces or sometimes even eliminates the dyskinesias. And that basically, is one of the reasons, one of the common reasons why people end up gaining weight, because, they were moving so much, they stop moving, they're still eating the same amount of food and they end up gaining weight. Carbidopa, levodopa helps with my anxiety, absolutely. As I said before, that it certainly can, and especially if you're coming to the end of dose and you take it closer together, it can definitely help anxiety without a doubt. Dopamine naturally occurring in foods. So yes, I mean, there is, Mucina pruriens, it's a plant, fava beans, all of these things have dopamine. But I really don't recommend anybody to start treating their Parkinson's disease using the plant or fava beans, because you don't know what is the quantity of dopamine in these medicines. In your levodopa, carbidopa 25/100, I know that 25 milligrams is carbidopa, 100 milligrams is levodopa. When I start a patient on half tablet 3 times a day, I know I'm giving you 50 milligram 3 times a day. If people start taking natural foods, you don't know how much is there, and then you may not get enough, and or if you eat a lot, sometimes it may be too much. So trust your MDS, like Shelley calls them, movement disorder specialists. Okay, how do you differentiate between if you have a symptom that is occurring because of wearing off, which may be the same symptom as having too much medication? I'm trying to understand the question. Well, those are two different things. So basically, the question I'll ask is this. So I basically draw a graph, and the graph is like a y-axis and an x-axis. Okay. So the x-axis is the time interval between the doses. So the question that I will ask is, you take your medicine at 8, what happens to you? Like, do your symptoms get better? Is your tremor better? So if I want to know if the magnitude of the response is very good, then I want to know if you're taking 2 tablets, what percent are you better? Are you, is your tremor 80% better, 90% better, just 10% better? And then the other question is duration of the response. So basically, is the medicine lasting in between doses? So if the symptom happens only when the medication is wearing off, but it doesn't happen when you are on, then that's likely a wearing off symptom. But if a patient says, I'm not really wearing off, and then they're having some symptoms, then it could be the magnitude. So each individual dose that is causing it. And Sherry, I will say that this is not always easy to distinguish, but it's just taking a detailed history. Sometimes I will reduce the dose of the medicine and see what happens, or sometimes I will reduce the interval between doses. So it is trial and error. It is not, it's not such a just one answer. How do you spell that psychosis drug? I will spell it, and it is Nuplazid, or generic name is Pimavanserin. Okay, what else, Shelley? I think
I've got some more questions here that were submitted with registration, but for those of you who are joining us live on Zoom, get your questions ready. Don't be shy. And if you don't want to ask them verbally, you can put them in the chat box. Here's one. Someone with PSP asks, any suggestions for dealing with impulsivity and some aggression?
Yeah, so that's that's hard. And there aren't any perfect medications. Now, some of the impulsivity does come from levodopa, because remember, dopamine agonists cause impulse control disorders. Levodopa by itself can cause a dopamine dysregulation syndrome. But impulsivity in PSP is really part and parcel of the disease itself. So there are some, mood stabilizing drugs that I use. I know there's case reports, with people using valproate, which is, Depakote. It's a seizure medication. We've used that sometimes, sometimes Seroquel. So it really is trial and error. But it is sometimes I'll reduce the levodopa dose, because really people with PSP are atypical Parkinsonism does not respond to Cinemed as much, and we try to go high up on the dose to see whether some at a higher dose they'll be better. But impulsivity is really part of the disease, and so we'll try some of these medications. You try, I think Depakote is something, and I know that Mike Oken's group also did a study with Depakote in impulse control disorders in patients that were taking, dopamine agonists. So those are some of the medications. Is CBD oil reducing symptoms of Parkinson's? So again, this is, very anecdotal. I haven't used it as a therapy, but patients tell me that they use CBD oil. What I have heard from patients, yes, and Deborah, you're right. that trileptal can also be lamictal, trileptal, or oxcarbazepine, and lamictal or lamotrigine, which are traditional anti-epilepsy medication. Those have also been used as mood stabilizers. That's correct, and they can sometimes help with the impulsivity as well. So what have I heard from patients with CBD oil? A lot of people say that their tremor gets better, that it feels like it has a calming influence. The tremor gets better, fatigue has improved is what I've heard, and sleep has improved is what I have heard with CBD. Anybody else has anything that they feel has improved? Which means you would have to say that you've tried it, but so if you feel uncomfortable, don't answer. And then, is naltrexone used for any mood-related issues in PD? Is that an alternate medicine approach? So, long time ago, naltrexone, low-dose naltrexone, this was a fad. This is, I think, when I was a fellow. Low-dose naltrexone was being tried for, so what is naltrexone? Naltrexone is basically, for people who have problems with opioid addiction. It's a medicine that's used for that. Opioids, pain medication, these are painkillers. They can cause respiratory depression. And so naltrexone has been used to reverse these side effects. And basically, has it been used as an alternative medication? No, I mean, we certainly don't use it, but I know that, there was this whole thing about low dose naltrexone being neuroprotective. And I had a patient that basically literally was like bombarding me with phone calls every day. You're a movement disorder doctor, you're a PhD, you should think outside the box, you should give me this medicine, you should write this. Firstly, I'm like, not a pain medicine doctor. I don't prescribe naltrexone. It's not something that I prescribe. If it does not have a proven benefit, that, it's not something I can use. CBD oil helps me with regular bowel movements. Okay, well, wonderful from a patient. Our anti-epileptic drugs, don't they all increase the chance of suicide? If you look at a lot of the medicines that do something to the brain, perhaps one of the side effects listed in the prescription information could be this medicine increases your risk of suicide. The antidepressants by themselves, I remember a long time ago when I was in training and the SSRIs were introduced and the risk of self-harm went up, and they attributed it to people with depression, developing more insight into the situation, and hence, basically attempting self-harm. So short answer is yes. Long answer is we always monitor side effects and monitor doses. Any traditional therapy to reduce symptoms of Parkinson's, for example, massage, yoga? I think, yeah, I mean, short answer is yes. I think long answer is that the best way to improve the symptoms of Parkinson's disease are optimal management with dopaminergic medications. However, stretching, yoga, massage, all of these things can be used as adjunct therapies, and they can certainly be helpful. But you have to remember that, without your medication, they will not help you as much as they will. If your medicines are optimized, then I certainly, I think massage and people tell me that massage helps them with their stiffness and rigidity. So, it's expensive, but if you can afford it, why not? And then yoga, I think is, yoga I highly recommend. I do a yoga thing called sun salutation. I wouldn't recommend for everybody with Parkinson's to consider it because it has some poses where good balance is required. But I think that just, sit down and simple yoga poses as well as meditation, I think is very, very important. And it's very helpful. I think, we don't use adjunct therapies that much. Speech therapy. Yes. So speech therapy is, management of Parkinson's disease is a multidisciplinary and a multifactorial approach. Number one is appropriate diagnosis. Number two is optimization of medical therapy. Number three, identifying patients for advanced therapies when their disease progresses, such as deep brain stimulation, the duopa, levodopa, carbidopa intestinal gel, adjunct therapies such as apomorphine pump, which is right now not available in the US, but other therapies. I mean, psychiatrists, people with Parkinson's disease may need to see a psychiatrist, may need to see a urologist, may need to see a gastroenterologist. But Speech therapy, physical therapy, and occupational therapy are cornerstones. They are very important. There are two Parkinson specific speech therapies. One was the traditional LSVT, which is the Lee Silverman voice technique. Lee Silverman was the first patient on whom this research was conducted. That's why it's called LSVT. And it's called LSVT loud for speech therapy. And using the same principles of, large amplitude, but, slow movements, they developed LSVT big, which is PT. But Samantha Ellendery here, with the Parkinson's Voice Project, has developed a program called Speak Out, which uses not just traditional speech therapy techniques, but also uses some cognitive, intent that helps. And I've been very proud and fortunate to have written 2 papers with their group with the use of the, Speak Out in patients with Parkinson's. Take a walk every day. That is a key. Absolutely. I highly recommend for everybody to take a walk. Of course, be very careful. If your balance is a problem, take your walker with you, take your cane with you, go with a friend, go with a partner, be very careful, identify, any bumps on the road. If you're walking in your house, be careful with dogs and cats and carpets. Certainly don't, yes, Parkinson's Voice Project in Richardson is wonderful. I agree. Tai Chi is good. I think Tai Chi is really good. But, I worry about Tai Chi in patients. Again, it's just the yoga poses, balance, Now, Tai Chi can sometimes help with balance, but if your balance is not good, I'm not sure that, Tai Chi, I don't want anybody to fall. Free exercises. Oh, yeah. And Shelley says, which is true, that since the pandemic, Samantha has been kind enough to give her own time, 10 a.m. Central, go to Parkinson's Voice Project website, join in with Samantha. I join in sometimes. And then do the exercises for an hour. They also have free videos. So you can basically, if you're not able to make it at 10 o'clock that day, you have another appointment or somebody came to visit, then you can use those videos. But here's what I tell my patients. There was a patient and the spouse said, oh, my husband's having difficulty swallowing and, he coughs all the time when he's eating and he chokes on bread. And I said, do you do your speech therapy? And he said, no, I don't like speech therapy. And I like to him and say, okay, say, how many days out of the week do you eat? And he looked at me like, looks like Chitnis is losing her marbles. What kind of a question is that? Of course, you eat every day. I'm like, okay, if you want to continue to eat every day, speech and swallowing are very intricately connected. Do your speech exercises every day so that you can eat every day. And then my wife started laughing, but it's not a joke. It's true. One of the, the worst and the commonest causes of death in patients with advanced Parkinson's disease is aspiration pneumonia. And this is something that is relatively, preventable. I like for patients when they have a new diagnosis to have a baseline evaluation with both speech and physical therapy, sometimes even occupational therapy. And the patients say to me, why? Like my speech volume is good, or, I don't have any balance issues. And I'm like, it's very nice to establish a baseline, and a speech therapist or a physical therapist who's a specialist in that area may be able to pick some minor inefficiencies that I may not be able to pick. So it is really important that you get a baseline. And what they may say to you is, go away, everything's okay. If your speech volume starts to go low, come back and then we can do therapy at that time. Sometimes they may say, wow, you need your speech decibel need to be about 65 and you're only 58. And they're like, well, I don't think I have a problem, but the low speech, low speech volume is problematic. Socialize. Yes. I mean, I think that's really important. Having a sense of community has been very important. I mean, I really love, Dallas Fort Worth. And one of the things I tell Shelley is, my chances of ever moving out of Dallas Fort Worth are quite, minimal to zero. And the reasons for that are many, but, I mean, I love UT Southwestern. I love the work I do there, but it's the patients. It's you guys, lovely, lovely, lovely patients, lots of facilities in DFW. Unfortunately, I had to diagnose somebody young with Parkinson's disease very recently. And I told them, I said, I'm sorry you have Parkinson's. We'll take very good care of you. But if there is any place, in the US where, where you would live with Parkinson's, Dallas Fort Worth Metroplex is certainly a great place. You have, you basically have like we may be close to, 8 or 9 movement disorder fellowship trained specialists now. We have the physical therapist, speech therapist. We have one of the world's top neurosurgeons now that has come to UT Southwestern that does deep brain stimulation. We've done tons and tons of surgeries in the last year since he has come, and the implants have been fantastic. Put a big plug for him. So lots of facilities. So swimming, yes, I think swimming is good. Here's a word of caution. If you have a deep brain stimulation device, be very careful. There were some reports that came out that, because there obviously some kind of alternate pathways that are involved in the movements that people do when they're swimming. And it was found that people with DBS somehow, had difficulty performing those movements and were at risk of drowning. So if you have a DBS device and you want to swim in your swimming pool, I suggest that you have somebody right there, somebody that can jump in, help you, somebody that's watching you. I'm very trepidatious of swimming in DBS. At what point in the progression of Parkinson's do you recommend evaluation for DBS? Like meds no longer work? No. This is a myth. Meds, medications, levodopa, carbidopa always works, even in advanced Parkinson's patients. As the disease advances, you may require more at each dose than what you were taking. You may require to take it closer together. So if you are taking 3, then you could be taking 4 a day, 5 a day, 6 a day. My general rule is a couple of things I keep in mind. Once a patient takes medicines 4 times every 4 hours, that's when my antennas go up, because any less than 4 hours, I think, is very close together. The minute the patient starts to have even the slightest amount of dyskinesias, my antennas go up, and then I keep an eye on my patient. I keep in my mind that this particular patient would probably be a candidate for DBS in the next 1 to 2 years. So I started, I'm DBS trained. Not all Parkinson's specialists are DBS trained. And so because I'm DBS trained, I know, when to start looking for these people. And I usually start picking people, when they start to have even slight motor fluctuations, dyskinesias. In advanced Parkinson's disease, the medicines sometimes don't work because people can develop what is called gastroparesis, or slow transit through the gut. And then you may not absorb, medications, and that's why they don't work. But medicines, if you're able to get enough dopamine to the brain, they work. Does Parkinson's affect one side of the body? Yes. So the onset of Parkinson's disease, is always on one side of the body. They usually start on one side. If you get a DAT scan, we see that the uptake is lower on the other side of the brain. Why does it start on one side? I'm not sure anybody knows that answer. This question has been asked again and again and again, but it does start asymmetrically, and then people may remain asymmetric for, quite a few years. Sometimes I have people that remain asymmetric for 4 or 5 years, don't have any symptoms. Eventually, as the disease progresses, it will affect the other side. Now, somebody comes to me and says they have symptoms of Parkinson's disease. They started about 3-4 months ago, and they are very symmetric. That's a red flag for me that this may not be the garden variety idiopathic Parkinson's, and this could be, so symmetric forms of Parkinsonism can be medication-induced Parkinsonism. It can also be some atypical forms of Parkinsonism. So those are kind of red flags. Balance issues, with PD, recommend physical therapy for resetting crystals in the ear. Only if you have, have like vertigo. The Epley maneuver and the, vestibular PT that helps for resetting crystals in the ear is for people, who have vertigo. Patients with Parkinson's disease can have vertigo, but not everybody has vertigo. So, the vestibular therapy is only, basically if you have vertigo, is the sensation of spinning, moving, either your head's moving or the room's moving. And I think that vestibular therapy really helps. Boxing specific to PD is excellent. I agree. Boxing is very good. Just be careful to not hurt yourself. Be very careful with balance, because you're stepping back and forth when you're boxing. But I do not disagree. I said I'll never leave DFW, and I live in Houston now. Well, hopefully you'll come back, John. A tornado warning. Be safe. Thanks for joining us. laugh out loud or John Race. Shilpa probably won't be following in your footsteps. I don't think so. Who knows, but hopefully not. My dad is always cold even when it's 100 degrees. Is that another symptom of Parkinson's? Uh, you know, I don't know, because sometimes when people are low on medication, I have heard people saying, I feel really cold. And, so temperature regulation, I think, can definitely be affected in Parkinson's disease. So short answer is can happen. Yeah, feeling cold, can be a Parkinson's symptom. It can be related to medication, wearing off state. DBS and swimming. First time swimming after DBS, that happened to me. I couldn't swim in deep end. It's like I forgot, I almost drowned. Oh, jolly. Sorry about that, but I'm glad we have educated the community now. Any supplements that can help? Really nothing. I mean, there are no, multivitamins, vitamin B12, because levodopa can interfere with the absorption of vitamin B12. So I always ask people to check vitamin B12. If it is normal, don't do anything. If it is low, correct it. Low B12 can cause neuropathy. Low B12 can cause memory problems. Vitamin D is another supplement, because, vitamin D and calcium are really important, because, patients can certainly, have a high risk of falling. And so you want to make sure that your calcium and vitamin D levels are good. So those are supplements that but multivitamins in general. I mean, there are some different ones for seniors. There's a 50 plus. I mean, when I take biotins, that's for skin, hair, and nails, but those are generic, not Parkinson's specific, things. And yes, I most certainly will be doing these things. Shelly and I intend to continue. Our goal is to make the DFW Parkinson's community the most educated community in the entire US, in the entire world, if possible, so that you guys can be very educated and take good care of yourself. So my husband developed orthostasis after 25 years with Parkinson's. That was some Parkinson's. Catherine, you are absolutely right. Orthostatic hypotension can be terrible. This can happen with advancing Parkinson's disease because of involvement of the autonomic nervous system. We can manage it. I mean, drink a lot of water. We reduce the dose of levodopa sometimes, but there are add salt to your diet, use compression stockings, drink a lot of water, raise the angle of the bed by 30 degrees. There are medications. There is midodrine, Florinef, and droxidopa. These are three main medications. There are a few others. DDAVP is one, and pyridostigmine. These can all be used to raise the blood pressure. Do we have to take levodopa with an empty stomach? For the most part, that's what we recommend for people, because food can interfere. If there is food in the stomach and food in the intestine, it can interfere with the absorption of levodopa. What can happen is people can have, low, can have a delayed on time, or can sometimes have a no on time. So delayed on, no on, especially if you take protein. Then proteins are broken down into amino acids. These are the building blocks of protein. Levodopa is amino acids as well. And so there's an interference with absorption, and you may not absorb enough levodopa and may not get a good on time. Yeah, so he takes all three. Yeah, that is, but try compression stockings, give him a bag of chips to eat, salt tablets, all of those things are, and drink. I mean, if there is no contraindication, drink a lot of water. I had to stop B12. It got too high. Yeah, you just have to monitor. Sometimes B12 can get high. Yes.
Those are all the questions in chat. We do have one more question. For those of you guys who need to hop off, feel free to.
Yeah.
Just one last question. How is PD dementia diagnosed, and how can I get my very combative spouse tested for dementia?
Yeah, so Parkinson's disease dementia, can develop as in advanced Parkinson's disease. A very high percentage of people with Parkinson's disease, are at risk of developing cognitive dysfunction and dementia. The way to diagnose it is basically, the simple screening test that we do is basically called a MoCA, or a Montreal Cognitive, assessment test. Of course, very detailed, neuropsychological testing, that is, 3 to 4 hour sessions are done by the neuropsychologist, and they can be tested for that. But like I said before, making sure that this is truly Parkinson's dementia, always look at infections, metabolic stuff, look at medications that can, there are other medicines like, oxybutinin. That's a medicine that's used basically for treatment of urinary symptoms that can cause, cognitive symptoms. Low thyroid can cause cognitive symptoms. So there's a, you just need to see a movement specialist or a behavioral neurologist. And you were diagnosed with PD dementia at 39? Really? No. That's quite less likely. Even people that develop Lewy body dementia, 39 is a little early for that. John, you need to come back to Dallas so that we can evaluate you and see what's truly wrong with you.
I like how she took that opportunity to tie it back into a call to come back to Dallas.
Yeah, well, thank you guys. Happy to do this. We'll have a session next month with Dr. Lang, and then the next one will be, and feel free. I mean, I don't mind doing just a generic thing like this, just answering lots of questions. Shelley as well. Maybe they can submit lots of questions, or if they want to, pick a topic and talk about it as well. I'm happy to do whatever that the population wants to do. I mean, I'm here to help you guys. Thank you, Pat. You guys are great as well. You guys inspire and motivate us to do what we do, right, Shelley?
Absolutely. Thank you guys so much for being here. I know that we probably didn't get to all of your questions. It's hard to squeeze all of the questions in on a topic like this within an hour, but thank you guys so much. We absolutely love what we do. We love you guys. We support you. We want to help you in any way that we can. So please reach out to us and let us know what topics interest you, what questions you have, and we can always base our Chillin' with Chitnis sessions in the future on that. I do want to say something about Tai Chi and boxing because I saw some comments about that in the chat box. As Dr. Chitnis mentioned, there are some risks with that, with balance and falling. So we obviously recommend that you do that under the supervision of a trained professional. Here in Dallas, we've got a company by the name of Tribe Wellness. They're a Parkinson's community organization, as well as a physical therapy practice that specializes in Parkinson's. And we have a partnership program with them. They do provide boxing and Tai Chi. So if that's something that you're interested in, please feel free to reach out to me and I can get you connected with them. The partnership program is a financial assistance program. So if finances are a restrictive factor in you getting the help that you need, we want to make sure that we get that taken care of on your behalf. So feel free to reach out to me and we can get you set up with that. Thank you guys. Let's see. They also do a great one-on-one Parkinson's PT. Sherry says, yes. They also have one-on-one Parkinson's physical therapy, and we do have a grant that we have given them for that as well to cover copays and any other out-of-pocket expenses. So if anyone is interested, let me know. As Shilpa mentioned, next month we have an Ask the Doctor webinar on cell-based therapy and immunotherapies in Parkinson's. So I know that that's another topic that a lot of you guys
genetic.
On, and genetic, that's right. So cell-based genetic and immunotherapies in Parkinson's with Dr. Tony Lang from the University of Toronto. Registration is open, so please feel free to head over to our website tonight before you shut down your computers and devices for tonight, skypassfoundation.org, and you can get signed up for that. I believe that's on May 17th at 7 p.m. Central. And with that, I guess we will wrap it up. Does anyone else have any final thoughts or comments to share? Going once, going twice. Okay, guys, thank you so much. Have a wonderful rest of your night, and we hope to see you again soon.